How many have registered for this course?
So we don't have up-to-date figures because the system's crashed, but as of last Thursday, there was, I think, 60 people.
60? Oh,
Yeah.
large number. Oh. Do you offer it free for the participants, or you make a charge?
So if participants would like to attend and collect CPD points, then there's a charge. Otherwise, it's free and open to anybody to attend.
Oh, okay, makes sense. That makes sense.
But what happened, Shari? There was only 10 people registered, and then I put your name in the advertising, and then the numbers just went through the roof.
That's just a coincidence.
I had to turn people away.
That's interesting. What a coincidence.
I thought to myself, there
well,
must be
I have been
delivering
CPD, CPD for 3 years, so
okay.
Some know me by name.
Yeah,
but this may not be the case.
So you're well known. So I said to Sahar, we should get Sharia doing all of our CPD events. We'll boost the figures.
Yeah, true.
Hi, good evening.
Good morning, Sohad. How are you doing?
I'm good. How are you?
Yeah, very good, thank you. We're just about to start, but I think you're good with WebEx. You know what you're doing.
Yeah. We are well skilled at driving on WebEx.
Excellent. Yeah, Tanya said that you're an expert. Okay. Okay, so it's 6 o'clock, so we'll make a start. So welcome everybody to this CPD session, the first of 2021. Thank you for joining us this evening. I think it's probably the best way to spend Valentine's Day joining us in the CPD session. So well done, you've made a good choice. Before we start today's session, I would like to just share with you some of the updates we've made to our CPD registration. So what I'm going to do, I'm going to share my screen with you. So in the past, we would be emailing you the evaluation form. However, we've now made a change to our current practices, and now to claim your certification, you will have to go to our CPD website, which I'll share with you now. Okay, so I think you can see the events page on the CPD website. So if you would like to claim CPD points certification, you'll just need to click on the CPD evaluation link, complete the questionnaire, and you will receive a certificate within 7 days of the event. It's important that you do complete this CPD evaluation within 7 days of attending the advertised event. And as well, I'll take just a minute now just to introduce you to the other topics we're running this semester. So this is the first in a 3-part series in which we're collaborating with the College of North Atlantic on healthcare and ethics. So today we have part 1, Introduction to Medical Ethics. And then on Tuesday, we hope that you'll join us for part 2, which is Genetics, Genomics, and Islamic Ethics. We have Dr. Mohammed Ghali from HBKU joining us for that session. And the final session will be next Sunday, and it's Interprofessional Ethics Towards a Common Framework, where we have Dr. Isam Al-Din from PHCC, who will be presenting for us. Next week as well, we'll be beginning our Diabetes Care and Management series. So this is a 6-part series in which we have experts from both within Qatar and from international institutes who will be joining us and presenting on various topics regarding diabetes. Today we've also added another session which will shortly go up on our website, which is around medication wastage and managing medication wastage, and that will be delivered at the beginning of March. So we hope that you'll join us for each of those sessions. And like always, we encourage your feedback and participation in our sessions. I know the presenters today, they're expecting lots of questions and interaction from you. I also want to draw your attention to our monthly newsletter. So if you're currently not receiving our monthly newsletter, you can drop us an email. We can add you to our mailing list. And in the first week of each month, we send out a newsletter which gives you an update of upcoming events, what's been happening. For March's newsletter, we do want to include a piece on participants' experience. So if you'd like to share your experience with us being involved in these events, then please get in contact with us and we can include you in next month's newsletter. So at this point as well, I'd also like to welcome our viewers on YouTube. So you should be able to view us both on WebEx and on YouTube today. So that's my introduction. I will now be introducing our speakers for today. So we have 3 excellent speakers. We have Mr. Sharif Sadiq from the College of North Atlantic, Dr. Suhad Tahir Nashif, and Dr. Tanya Kane, who will be presenting today's topic. So I'll now stop sharing the screen, and I will let Mr. Sharia. Okay. Stop sharing. Okay, Mr. Sharia, I will now make you the presenter, and you will now be able to share your slides.
Okay, good evening. Assalamu alaikum. Welcome to this introduction of the ethics and healthcare. So I'll be just giving you a short introduction of the whole series, and the other speakers will go into more depth about this ethics in healthcare. So what I'm going to highlight today, and what you're going to learn in this first half an hour session, is how do we differentiate the meaning of value, moral, and ethics? Sometimes these three terms, it's sort of overlapping. The meaning is overlapping, but it has some distinctions. So there are some fine lines to distinguish. So I will try to distinguish the meaning of value, morals, and ethics. Then I'm going to talk about the universal principles of biomedical ethics. I'm just going to give you the outline and maybe talking a few minutes about each of those principles. So let's start with the value. Now, what is value? Value is something which is absolutely personal, a belief within someone that determines what should or should not be done. And where it comes from, it is absolutely someone's personal beliefs, and this gives a sort of understanding of a particular person about what I should do and what I shouldn't do. So it's an insight, a perception. This values is not permanent on someone. It may change from time to time. It is not deeply rooted in someone's feelings. So this will change. And again, the values are not universally accepted. It varies from person to person, even within the same society, within the same community, same professions. Two persons may have two different values. Now, where do we get all these values from? What are the sources of these values? So learning process, the way we learn from the childhood, we are taught to behave in a certain way, such as don't lie, don't cheat, steal, don't fight, or don't swear. This we learn from our school, from our parents, then through some personal experience. This will widely vary from individual to individual, depending on under what circumstance a child grows up. Some may grow up in a very difficult situation. Maybe they're facing some loss of a near and dear in a war zone area, displacement from home, physical disability. All these circumstances will give a different values in comparison to someone who have been growing up in a very comfortable environment. So there will be a difference in developing the values between these two individuals. The third source is modeling. Some people, they follow a specific individual. It could be their parents, maybe the mother or the father, could be a teacher, or it could be just a role modeling someone superstar or whoever it is, just modeling by some person. They developed slowly within themselves some type of value. But again, these values are not permanent. Now let's see what is moral. Moral is one step higher, I would say, than the values, because the morals comes from a broader perspective, from the cultural side, from the religious teachings, from the social environment. All religion, culture have some set of values, and these values are quite guided, and this gives some individuals some more in-depth understanding about their perception. So this becomes a little bit more in-depth than the values. These are sets of principles which comes from society or culture, and this teaches us what is right and what is wrong. And these have a much more broader acceptance within that particular culture or religion.
Mr. Sharia,
Yes.
we have a question from one of our participants, and
Okay.
so the question is regarding morals. Could there be circumstances that one's morals are in conflict with accepted standards of care delivery, and how should healthcare professionals respond to this?
Definitely. I would. This answer would be more appropriate once I complete the principles of healthcare ethics. But if should I wait until that point, then the answer will be more relevant.
It's up to you.
Yeah, I think that would be better. Then the person who have asked the question will have a better understanding.
Sure.
It's in my mind. The question. I will definitely answer the question. Okay.
Okay.
So it's an effort to lead a good life. And why these morals, we learn these morals? The intention is to be a good person and to lead a good life. And usually they don't deviate very easily from someone. It is much more deep-seated than the values. So it is a distinguishing between the right and wrongs. So there are some common morals irrespective of the religion. All religions teaches the good things to do. Be truthful, be kind and generous, be loyal, be patient, do not cheat, do not hurt. These are some of the fundamental morals that we learn from religious values, social values, from the learning environment. Now, ethics is even one more higher than the morals. Ethics, it's not that comes only from the society or a religious environment, but it is guided by some specific rules and regulations to distinguish between the right and wrong. So this right and wrong distinction is based on certain rules and regulations. Now, this rules and regulations is more applicable in a professional setup. It is consistently applied to a professional group, and different professional groups will have different ethics. Although ethics is not a law, it's not that if someone deviates from one ethics, he will be penalized or punished. It's not a science. And also, it is not someone's personal feelings or religious value, even though that may be acceptable to that religion, but that may not be acceptable to the professional group. So it is guided by specific rules, but it is not a feeling about which is aligns with a religious value. So this is yes, please.
Yeah, we have another question, and this one looks like it's regarding ethics. So, how are the ethics for each profession decided upon?
Let me answer the first question then. The first question, that the morals, someone may have a good moral, that means trying to be a good person, but all those moral values, the question was, does it conflicts with ethical principles? Certainly it can conflict with ethical principles, because ethical principle is based on certain rules and regulation that is acceptable within the profession and acceptable for the general public, that is not specifically guided by a religious value. Let me give you an example. Say in a pharmacy, someone comes to get a contraceptive pill, which is after having a possible conception to have not to continue the pregnancy. And if the pharmacist thinks that this is against my religious value, but then he or she is going against the ethical principle, because the ethical principle is the patient has the right to buy that. Well, it depends on the society and environment. Say, I'm talking about the Canadian society where I have practiced there. So this is a very common medication. And if someone in that environment doesn't want to sell that drug, that becomes unethical from the ethical principle. But morally, that is correct, because his or her moral, maybe the religion teaches him or her that no, this is not correct. So here we can see that there is a conflict of the moral values and the ethical principles. I think I've answered to the first question. Should I continue and then give the answer for the second question?
Yeah, sure.
Okay. So the professional ethics, which I just talked about, deals with the specific duties and responsibilities that are required of professionals. Different professionals have different views of what constitutes the end good, and that is the answer to the second question, from how and the professional ethics is developed in one particular profession. The guideline is, the end point is what is good for the people. Eventually, all professions work for the people. And whatever is the end result, the good for the people, doing good for the people, not looking to my personal benefit or any of my organization, rather the focus should be on the end point, the public, the patients, the participants. They must get the best possible service, and that is what the professional ethics aims at. No matter what profession we are in the healthcare profession. It could be journalism, it could be engineering, but the end point is to satisfy the users, to satisfy the stakeholders, satisfy the patients, the public. So ethics in healthcare, now we are getting into the specific healthcare, relates to the choices made by healthcare practitioners and patients, and the duties and obligations of healthcare practitioners to their patients. Now, choices made by healthcare professionals, it is guided by the rules and regulations. It is a fundamental duty and obligation of the healthcare practitioner to follow certain guidelines which has been prescribed by the ethical principle. And accordingly, we have to exercise our decision, our act, which will reflect the professional ethics and which will be good for the patient, good for the profession, not for the individual or not for the institution. So the ethical principles, that is how the ethical principles are derived. Different professional groups have different ethical principles. So it is a collective of moral or ethical standards or judgments of good behaviors used in guiding ethical decision making. So the principles that helps us, that guides us to take the appropriate decision, although it may not be possible in all situations. That is where the dilemma comes. The other speakers will talk about those. Sometimes trying to fulfill the ethical principle of one part may contradict with another ethical principle. Okay, so what does a code of ethics do? Now, the ethical principles, under the ethical principles, there are several code of ethics. Now, this code of ethics gives a guidance for how we should take our decision with our set values and specific for that particular profession. Those who are newly entering into the profession, it gives a guideline to them that what is expected by the profession and by the people. It informs other healthcare professionals and the public. The public can, the citizens, the patients can expect that I am under the care of a professional, and I can expect the best possible service from this particular professional. It provides the member a means of self-evaluation and reflection. After taking a decision, whether it's right or wrong, healthcare professional should always reflect upon that and try to evaluate that whether that decision was appropriate, whether I can could have taken a better decision. This also gives an opportunity to the healthcare professional to reflect on the decision they have taken. So code of ethics does not solve all problems. It is a guideline. Okay, some of the things becomes very in a gray area. Neither we can go to the right side, neither we can go to the left side. So it does not provide a strict laws also. Law has a strict yes or no thing. Ethics may not have always a yes or no thing. There are a lot of gray areas which we have to work with, and that is what makes our profession more challenging. Does not provide rules on which values should take priority in a given situation. Two healthcare professionals may give two different types of decision under the same circumstances, and each of them may have their own judgment, justification based on their thoughts. Could be both of them are right, could be both of them are wrong. So it becomes sometimes very difficult to come to a absolutely perfect yes or no decision. It does not solve every situation, just what I have said, and that may be faced by the professional. Now let's go through the pillars of medical ethics. Okay, there are four basic pillars of medical ethics. The first one is the autonomy. The second one is beneficence. The third one is non-maleficence. And the fourth one is justice. Now, in the different literatures, a universal principle of biomedical ethics, they have included some more components, more principles other than these four basic pillars of medical ethics. So in addition to autonomy, beneficence, non-maleficence, justice, there are some other components such as fidelity, respect, veracity, and confidentiality. So I am going to give you a very brief understanding of each of these pillars. So autonomy is the patient's right to take the decision related to their care. So patient may take a decision which was being given by the doctor, or the patient has the right to refuse the decision about their health care. So that freedom of thought, the patient can exercise at all time. Now, the healthcare professional's responsibility is to educate the patient, but not to influence the patient. The healthcare professional, they will provide information about the patient, about their disease, about the possible treatment, what could be the possible outcome. Obviously, the healthcare professional will have something specific to share with the patient, which according to the healthcare professional may be the best possible outcome. And he or she is going to explain to the patient that why this is the best possible outcome and what risk also it involves with this involvement. Now, he should also point out the alternative possible treatments and what are the different risks and benefits of that alternative option. But at the end, after educating the patient, it is the patient who has to take the decision. He has the freedom of making that choice and decision about his or her own healthcare. Next is the beneficence. Beneficence is the act of doing good with mercy, kindness, and generosity. At all time, the intention of a healthcare professional is to do good to the patient. All actions of healthcare professionals should be driven by seeking the best possible interest of the patient. And sometimes by taking a best possible action which is good for the patient may also have some negative sides, some disadvantages also, but to weigh out that which one is more, whether the the patient is getting more benefit than the harm, then that decision can be taken. So there are some principles of beneficence to do or promote good, protecting and defending the rights of others, preventing harm, removing conditions that will cause harm, and helping persons with disabilities. Now, the next pillar is the non-maleficence, which is closely opposite to the beneficence, such as not to do harm. Under no circumstances a healthcare professional's actions should cause any harm to the patient. Do no harm. Professionals have an obligation to not knowingly inflict harm or injury. Now, the harm or injury could be a physical harm or injury or emotional harm or injury. Well, taking a decision, a lot of decision will be associated with some type of harm. But again, what did I just mention? The benefit must overrule the harm. Say doing a surgery, yes, there are pain, there is a discomfort. That means, am I doing harm to the patient? But no, the outcome, the benefit of the patient is much more than the minimum harm the patient may get. So in one extreme, the harm could be do not kill, do not cause pain or suffering, do not cause offense to others, and do not cause a patient to feel helpless, isolated, or upset. So taking the physical aspect as well as the psychological aspect of the people. Again, all of these have some contradictions. Say, do not kill. Now, in some countries, the physician-assisted death is legalized, euthanasia. So that, now how would that be explained? The physician is killing the patient in one sense, but that is illegal. So all of these points, I mean, there are the other side of the coin. And as I told you that the medical ethics is not black and white always. It has a large gray area depending on the situation, circumstance. Different professionals may have different justifications, but as long as the healthcare professional can justify that whatever I have done based on the ethical principles to the best interest of the patient, that is what it is expected from a healthcare professional. Okay, it's a question for you, just for a short discussion. Moral could be in conflict. Actually, this was the question asked by someone, so we have already discussed that. Moral could be in conflict with the ethical principles of healthcare professionals. True or false? Anyone can answer, true or false?
It looks like the majority of our participants think that it's true.
Definitely, yes. So yes, there are a lot of occasions where the morals could be in conflict with the ethical principles. So yes, the answer is true. The fourth pillar of medical ethics is justice. Justice is more about the social approach rather than an individual approach. The autonomy, beneficence, non-maleficence targets the individual, but justice is more a broader concept. It's the society as a whole is involved. How it is involved? Because a healthcare professional should not only consider his or her own patient, but to have a consideration about all the patients. That means that every healthcare institutions have a budget maybe. Now, if someone utilizes a large amount of money treating his or her own patient and not leaving too much money for other patients, that becomes an injustice. So maybe the patient is, I know the patient is my relative, is my friend, so I will do whatever best for the patient. That is right, you're trying to do the beneficence, but if you are utilizing too much of the resources, then you are violating ethical principle. You're not doing justice. That becomes injustice. Next is the fidelity. The role fidelity is an obligation to faithfully practice within the expected duties of that role. So it includes loyalty to the patient, integrity, honesty, promise keeping, and trustworthiness. So a healthcare professional must exercise all these components when dealing with his or her patient. Veracity, to speak out the truth not to lie or not to deceive a patient. This is an absolute obligation of healthcare professional to express the facts of the health status of the patient. Again, there could be some obstruction to exercise the veracity. Maybe the patient's relatives are requesting the healthcare professional, maybe the physician, not to disclose, say if the patient is suffering from cancer, not to disclose this, because if the patient gets to know that I'm suffering from cancer, he will be down, and whatever number of months or days or years he's going to survive, that is going to be very painful. Now, what the healthcare professional is going to do in that situation? In one side, veracity, yes, they have to share the truth, express everything of the patient, and let the patient take the decision. Because particularly in cancer, the treatment options is wide varieties of treatment options are there. Okay. Now, if the patient is not aware of that, then it becomes a one-sided treatment. Okay. So yes, conflicts could be there. So all of these pillars and principles of biomedical ethics, we can have the other side also. Again, there is no black and white. There will be always dilemma, and you will have a better understanding from the other speakers today and the following days how the ethical dilemmas occurs and how to justify the best possible decision and how to resolve those dilemmas. This is a big challenge for the healthcare professionals. So yes, the healthcare professional, but I think above all, the healthcare professional should be truthful to the patient and do not faking anything, but to disclose the fact. Respect must be always there. All patients should be treated in a caring, respectful, compassionate, and sensitive manner. All people deserve respect, no matter from where he or she comes from. It could be a different race, a color, religion, national or ethnic origin, could be from different social or marital status. It could be of different gender, age, socioeconomic condition. Irrespective of any possible condition that we may think about, there should not be any distinction when exercising the healthcare to the patient. This is a moral obligation. This is a principle of one of the important fundamental aspect of the medical ethics. Okay. There should not be any conflict in fulfilling patient on autonomy and beneficence. True or false?
So participants, you can type your answer in the chat box. It looks like we're getting mixed answers. We're getting true and false answers.
This topic is something that it's not a law, it's not a science, it's not a black and white. That's why there will be all different answers. There should not be any conflict in fulfilling patient autonomy and beneficence.
So our participants are saying this does sometimes happen, that there is a conflict.
So that it is false. There should not be, I mean, this is confirming that there should not be any conflict between autonomy and beneficence, but it happens, a conflict between autonomy and beneficence. In real life, any of the participants can give any example, share your views from your own personal experience, where on one side is the patient autonomy and the other side is you're thinking of the beneficence. So you are in a sort of in a dilemma that if you want to exercise your opinion, that goes against the patient autonomy. But again, if you want to respect the patient autonomy, actually you're not doing good to the patient, you're doing harm to the patient. I would say this is definitely false, because there are a lot of occasions there will be a conflict between autonomy and beneficence. I think the broader discussion, I will leave it for the next speaker. That's more elaborate. She's going to describe explain more elaborately about the autonomy, and I think we will get this answer from there. Anyone wants to add anything before I end my presentation? I have my limited half an hour time, so I have already just half an hour, yes. So anyone wants to add anything?
So there is a question, and
Yes.
I guess this is to the panel. So regarding autonomy, if you as a healthcare professional feel that a patient under your care is being unduly influenced to make a certain decision, how should you react?
First of all, the concept of autonomy is the patient must give the decision without any pressure, without any influence. That has to be ensured. Otherwise, the healthcare professional has to interfere. This is one of the conditions of autonomy, that patient must be consciously in a sound mind, not distracted by other external influence, and giving the decision. That is autonomy. But if there is a pressure from family, from society, then the patient is not able to exercise his or her views. So that is not actually autonomy. That becomes a pressurized decision.
And at that point, the healthcare professional should
yes, interfere. At that point, the healthcare professional should interfere so that the patient can take the decision by himself or herself without any pressure.
Okay. Does anybody else have any more questions before we move on? Okay, so at this point, I'll introduce you to Dr. Suhad, who will be our next presenter. I will make you the presenter, Dr. Suhad, and you should be able to share your slides.
Yeah. Thank you very much. Okay, now you can see my screen, correct?
Yep.
Yeah, perfect. Thank you very much. Thank you, Dr. Shahriyar, for your brilliant presentation. I will focus basically on informed consent and the capacity. But before we begin on digging into details, I want to ask you, what is informed consent? You know, we talk about consent. Can you define what is consent? And please feel free to open your mic and talk. What is consent?
So participants are able to chat. They're not able to open their mic in this session. So
okay,
you can just
chat. I will
type
open
in
my chat box to see the, okay. Okay. So what is consent? Zakaria, am I able to see the chat? Because, okay, knowing the consequences of your decision. Okay.
So somebody else has said knowing the risks associated with the decision that you will make.
Okay, so we all agree that it's actually a kind of a process of communication between you as a healthcare provider and your patient that often leads to agreement to permission of care for care, treatment, or service. And every patient, as mentioned by Dr. Shahriyar, has the right to get information and ask questions, all the questions before procedures and the treatments. Now, why we need actually a consent? For what? What is the importance of consent? What do you think the consent has a major role in the healthcare system? What do you think? Why we need consent? Why we don't just do what we think is the best for the patient? We are the doctors. We are the people who knows what is the best for his health or for her, let's say, medical condition. Why should be a consent there? What do you think?
So they've said, Ali has said to protect the rights of the patient.
Okay, correct. What else?
And Fatima has said that to involve the patient in their own care.
Exactly. Thank you very much. So it is, first of all, respect for the patient's right to know. okay? It's also it's a legal document. So for example, if in the future, if anything happened to the patient, it can be kind of protection for either the patient or the healthcare provider, that the patient knew about the risks and knew about potential complications because the doctor already disclosed or explained about these risks and the patient signed this consent. In case the patient said, I didn't know about it, because there is no consent, okay, so then the doctor will be in troubles, okay? And the third thing, what Dr. Shahriyar before mentioned, the autonomy, respecting the autonomy of the patient. Now, the philosophical basis of informed consent rests on the principle of patient autonomy. So the patient autonomy is the basis for any consent. And for consent to be valid, the doctor discloses information to a patient who is competent, the patient understands the information and voluntarily makes decisions, which means there are three major principles that should be available to make a consent valid: informed, capacity, and voluntariness. Okay, so these are the three conditions. When the patient has capacity, okay, when the patient is able to make that decision, and I will elaborate about capacity later on. Where is the best place to seek the consent? To give you a hint, Dr. Shahriyar before said that there should be a pressure from the family. What do you think is the best place in the hospital, for example, if we are talking about surgery? Where is the best place to seek the consent from the patient?
One of the participants says prior to the surgery.
Again, what was the first two words?
Prior to the surgery.
Okay, prior, but where? In the corridor, in the where? In the surgery room, where it should be done, the consent itself, seeking the consent, where should be done?
So the patient's room or in a private space where the patient cannot be overheard.
Yeah. Okay, exactly. So it's in a private space that the patient can hear the doctor, hear the information, and also can ask all the questions, and the doctor can hear the questions and answer them also appropriately. And this takes us also to the question of who is the person that should seek the consent. Now, it depends on the law in every state. In some states, it should be the doctor or the surgeon himself, but in some states, it can be any professional who is involved or perform the procedure itself and knows about the procedure and its risks. So he or she can answer all the questions that raised by the patient and can also give properly the information, clear information and full information also to the patient. So what should the consent include? Basically, three things, okay? The nature of the procedure, the risk, and the benefits. And there is no need, for example, to discuss or to mention the very rare complications because you may cause panic to the patients, okay? So in most of the, let's say, legal systems, the consent, the informed consent should not include the rare complications of the surgery or of the medical intervention. Okay. So these are actually, we answered sorry, I did not begin with the objectives. I went directly to the content. But I just mentioned that I will focus basically on the consent and the patient capacity. Okay, so these are the questions that we answered: the why, the who, the 5 whys. Let us look at these 5 cases. Okay, sorry, 2 cases: medical student and medical resident. Okay, the first case, a medical resident is attending surgery as part of her gynecology rotation. Prior to the procedure, but while the patient is anesthetized, the consultant surgeon asks the resident to perform an internal examination of the patient, though the patient has not consented for this specifically. If the junior doctor performs an examination of the patient without her consent, would she be liable to charge off battery? This is one. The second case is a medical student, okay, the first of resident, the second of student, attends surgery as part of her general surgery rotation. The consultant surgeon asks her to scrub to assist during the surgery, though the patient has not consented to this specifically. Is it ethical for students to assist in surgery without consent? Would that count as touching a patient and hence battery? What do you think? Is that okay to ask medical resident or medical student to touch the patient or to do something without the consent, prior consent of the patient? Any ideas about this?
One of our participants would have mentioned. Did you mention emergency consent, Dr. Suhad?
Okay, from whom? The patient is anesthetized. Okay, he can't sign consents. Emergency consent from whom? The family, from whom?
So immediate relatives.
Okay, but there is no emergency here. It's a surgery that is going very smooth. Nothing. There is no emergency. Imagine that there is no emergency. Okay, but the surgeon asked the resident to do something, or asked the medical student to touch the patient. Is that okay?
So our participants, there seems to be general consensus with the first medical resident case that it's not okay, that shouldn't happen.
Exactly. So teaching hospitals in general should provide information to patients about the involvement of students or residents and trainees in clinical care from the beginning, okay? Given the sensitivity of, especially of intimate physical examination, doctors and medical students should obtain specific consent prior to performing this. Because one important thing is that, or one important reason for this is that sometimes we might reasonably expect that some patients would object to this sort of examination if we ask them. Okay, so it must be there a consent. And do you think there is difference between resident and student? Or it's the same? What do you think?
There seems to be, the general opinion is that yes, there is a difference between the two.
Okay, which is?
And some people are saying the same. There isn't a difference. So those who are saying there is difference, they're saying that the resident has completed their training, and the general differences between skills and experience.
Yes. Okay, definitely agree. The qualification is different, but the law is the same, which means the patient must know if there is somebody else other than the surgeon will do or touch or do anything with her or his body during the surgery. Okay. Now, if we look at this issue of hierarchy and the power relations, sometimes you can find maybe a doctor that asks the student to do something, and the students, because of this hierarchical relationships, they agree to do that, although it's not okay. So the students always, or even residents, if it's illegal to do it, they should say no, because if anything happened, they will be the person to, let's say, also to face the complications of the case, because sometimes the doctor asks the students and the students just shame to say no, and the doctor should be aware of these hierarchical relationships. So the doctor is responsible not to ask the student to do things without the consent of the patient. Now, and sometimes you can see that, you know, small things such as, I'm not talking about surgeries, but for example, I don't know, making a physical examination, the simple one, okay? So the doctor in general asks the patient if he or she agrees to have a student, and if he or she agrees that the student make this examination. In general, the people are nice and they allow, because they try to be nice to the students, but also some people prefer not to do that. But the patient right is to know that this person is student or resident. Because of that, on the small cards there should be written resident or student, etc., because even it's legally must be like that. Okay, let's move on to these dilemmas. Can one of, or any one of you, pick one of these dilemmas and maybe he or she faced it during his professional career or practice, and try to answer the dilemma? What do you think? Pick one and try to answer it. You can write the color in the chat and then your answer. Okay, I will ask and you will answer. A patient has signed a consent form for surgery. Does that mean that surgery can proceed? What do you think? Yes or no? Somebody said yes. Anyone thinks no? Well, the answer is no. It's not simply to sign. The most important that I assure that the patient understood also what he or she is signing. Okay, so it's not only to sign the consent, but also to be sure that he understood. Because of that, it's informed. I disclose, I explain to him or to her about the procedures, the procedure and the risks. Okay, how much detail do surgeons need to provide when obtaining consent? How much detail? As much as possible, okay. But it's important also to take in consideration that there is no need to go into, let's say, the rare complications of the surgery, okay, or the treatment.
So
okay,
as much as the patient can understand.
Sorry?
As much as the patient can understand.
Yes, but also, everything should be explained, which means every detail, important detail, should be explained using the language or using the way that the patient can understand it. Language that understood to the patient. Excellent. Yes, right. Okay. If the doctor does not mention one risk verbally, but the risk is written in the consent, does that mean he's legally in troubles if the risk takes place? What do you think? Yes or no?
So,
somebody said not really. Anyone thinks it's yes?
Some people say yes, some people say no.
Yes. He is, because he must inform the patient about the risks as well. Okay, it's not informed doesn't mean only written, but also should be should be informed or verbally told to the patient as well. Okay, should the healthcare provider seek consent from illiterate patient? What do you think? Yes, correct. Can consent be delegated? When does the therapeutic exception permit a medical professional not to disclose a material risk? What do you think? When?
Dr. Sahad, there are some questions coming in on the chat. So one of the questions was, I think, relating to if the doctor does not mention one risk verbally. So the question regarding that is, what if the rare complication happened? What if it was something very rare? What's the consequences?
Yes, of course. It's as I mentioned before, in most of the legal systems, rare complication, doctors are not asked to mention every rare complication that could happen. But if it's happened, sometimes there is kind of sentence in the consent that say there are very rare complications that may happen, but they are not going into details to these rare complications because sometimes it's endless. Drinking water has sometimes rare complication, okay? So they can't go into every rare complication. So rare complications should not be mentioned in consent form, okay? Moving on. Should the healthcare provide, no, we are in the yellow one, okay. What about the therapeutic exception? Can consent be delegated? What do you think? Okay, it's yes. Okay, the answer is yes. The answer is yes. Now, therapeutic exception. If a doctor decided that, for example, telling the patient of risks would be seriously detrimental to the patient's health, they can decide not to inform the patient of that risk. One example that can be given, for example, in the UK legal system, if informing the patient will cause him a panic attack or will cause him a severe mental health issue, it should be that the therapeutic exception is relevant. It can be used by the doctor, and the doctor acts based on the patient interest. Now, what is important here in consents, that it doesn't matter the issue of yes or no. The issue that what is matter is the law of the state that you are working within. So any doctor should really learn very carefully the law of any country that he works in, because the law in the UK differs from Canada, differs from China, differs from Qatar, differs from Jordan, differs. So it's very important. So I'm talking here in general, okay, in most of the legal systems, but also you should check in specific countries what is the law. Okay, maybe you will find a different law for these statements. Okay, when is the patient not able to make voluntary decision to consent to treatment? When he lacks capacity. And lastly, can the surgeon perform an intervention during surgery that may cause physical impairment, but it saves the life of the patient? What do you think? What do you think about this? The answer is in the next slide. Yes, thank you, Ines. Yes, the answer is yes. Why? Because the doctor has the ability legally to decide based on the interest of the patient in some cases. Okay, when the patient lacks capacity and there is no relatives that they can be consulted, and also it's an emergency decision that he must take the decision on the spot. He doesn't have time. It's either to make the decision or to lose the life of the patient. Okay, so there are principles related to the consent. The first one is that a person is legally adult at the age of 18. The second thing is adults with capacity have a legal right to refuse medical treatment or demand withdrawal of treatment, even if this refusal results in death or permanent injury. If they have capacity, they have the right to refuse or to oppose to a medical treatment. Third issue is that adults without capacity should be treated in their best interests. Okay, and this is based on the doctor's decision, what is the best interest of the patient, but also in many cases, the opinion of the family also should be considered and taken into consideration. Another thing is that doctors can make decisions on behalf of an adult who lacks capacity. And this answers the last dilemma in the previous slide. Another important thing is that a parent or a guardian can give proxy consent on behalf of a minor aged less than 18. Parents and guardians are under a legal duty to act in the minor's best interest if doctors and parents cannot agree on the minor's best of interests. So a court may need to decide either who should judge best interest or whose best interests are. So this should be decided by a court if there is disagreement between the parents and the doctors on the best interest of the patient. And lastly, a medical professional who fails to disclose a material risk to a patient can be liable in negligence. Okay. So moving to patient capacity, okay? What is capacity? Let's begin with the definition of capacity. What is capacity? Dr. Shahriyar defined it before. What is capacity? Very simple, okay? The ability to give or withhold consent. This is the simplest definition of capacity, okay? Let us look at this case. By the way, these case studies are quoted or taken from a very from excellent book titled Medical Ethics and Law. The authors are Wilkinson and it's a co-author, but the main author is Wilkinson from 2020. So let us look at this case. Mr. B was a 73-year-old man who lived alone and had no significant family or friend. No family, no friends, okay? He had long-standing schizophrenia as well as diabetes. He had a diabetic foot ulcer and had been an inpatient in acute and rehabilitation hospitals for over a year. Mr. B was refusing all treatment for foot ulcer apart from dressings and had developed gangrene of his foot. His doctors wished to perform a below knee amputation and believed that without this, he would soon develop septicemia and die. Mr. B expressed that he was not afraid of dying and was strongly opposed to surgery. Should he be treated against his will? What do you think? Yes or no, and why?
It looks like our participants are confused with this one. We've got yeses and nos.
Okay. And this is a bit really confusing. And to solve the confusion, there should be psychiatrists who make evaluation in order to decide that at the moment of taking the decision, he lacks or have capacity. In this case, which is built on true story, actually he had been assessed to lack a capacity and that he was treated against his will. Okay. Let us look about these phrases and try to understand the differences between them. Capacity and capability. Do you know the difference between them both? Since I'm limited in time, I will begin to explain the difference between these phrases in order to also to give time to my colleague, Dr. Tanya, after me to have her time. So let's begin with capacity and capability. If we begin with ability, ability is the skill or competency to perform a task. So capacity is the ability that exists at present, whilst capability refers to the higher level of ability that could be demonstrated under the right conditions. Now, I will give you an example to make it easier. For example, I have the ability to run, okay? I have the capacity to run 200 meters race in 50 seconds. I have the capability to improve my capacity through training to 40 seconds. Okay, so this example can give the difference between them both. Now, what is the difference between legal capacity and mental capacity? Legal capacity is everyone has the right to have legal capacity, especially after the age of 18, which means the formal ability to hold and exercise rights and duties. Mental capacity, the decision-making skills and competencies of a person, and it differs between different persons. Now, an important thing that I want also to present here is the difference between the positive law and Sharia law, because the combination between them in many Arab Muslim countries is the civil law, okay? So in many Arab Muslim countries, the civil law combines positive laws, which are human-made laws that apply or specify an action, and Sharia laws, which are the Islamic law that derives its provisions from the Holy Quran, from the Sunnah Nabawiyya, which are the actions, behaviors, and statements of the Prophet Muhammad, peace being upon him, and from the rulings of Islamic scholars that basically based on the Holy Quran and Sunnah Nabawiyya. Now, in Islam, legal capacity called dhimma, in Arabic it's dhimma, and refers to description presumed in person, rendering such a person a possible candidate to receive legislative injunction. Now, legal capacity refers to the power that qualifies individuals, what's called al-ahliyya, okay, to secure and exercise rights and privileges while being capable of depravity. Now, under the Sharia law, legal capacity involves also privileged duties and responsibilities exercised by the individual. And the legal capacity does not only cover the potential of an individual to acquire rights and obligations, ahliyat al-wujub, but also what called in Arabic ahliyat wujub, but also the capacity to exercise, execute, and perform such rights and duties, what called ahliyat al-ada. So there is duties and there is also the ability to exercise, ahliyat al-wujub. Now in the Qatari law, especially in law number 16 for 2016, the mental health law, like most of the Arab Muslim countries derives from the Sharia law, defines mental capacity as the ability of the patient to understand and perceive the procedures and information presented to him, and to make the correct decisions based on this perception. So it doesn't so much differs from the international or from the what we know in different legal system internationally. Okay. Now the person is unable to make decision or lacks capacity in 4 conditions. The first one, to understand. If he unable to understand the information that is disclosed by the doctor, if he unable to retain that information, if he unable to use weight that information as part of the process of making the decision, or to communicate his or her decision. So he has to understand, to retain, to use weight, and to communicate. Now, the question is, can we assess capacity? Of course we can. Going back to here, so the doctor has to assess if the patient can understand, so the cognitive and the mental skills or the abilities. If he can understand, if he can retain, if he can use or wait, if he can communicate his decision, and also to evaluate his mental health status, but also to evaluate if there are ways to enhance capacity. And there are really ways, very interesting and very practical ways to enhance the capacity of the patient. To enhance the capacity of the patient, there are different steps that can be done by the healthcare provider. For example, to give a mental health treatment if there is a need for that. If capacity is likely to improve, we should wait, okay, if possible, until it does improve, and then to seek the consent. It's important to be aware to the impact of some medications, because some medications may cause the patient not to be able to give consent. Okay, he's not mentally capable to give the consent. If capacity fluctuates, the doctor should assess capacity when the patient is at her or his best situation. Okay, environment should be minimized distractions, but also should minimize influences, for example, from the family, such as mentioned by Dr. Shahrayar, and also rethink having his or her relative or beloved, because maybe having his beloved may help him to give a decision, or may help him to be, let's say, to be cognitively and mentally able to give a consent, to understand, to retain, to wait, and to communicate. And lastly, the explanation should be made simple, and sometimes even using illustrations, maybe using tools, especially with patients that we know that they cannot understand our language appropriately. So there are 4 possible approaches to make decisions. The first one is to best interest, which can be assessed by looking at the patient's wishes and feelings, his or past wishes and feelings, beliefs, values, and other matters. The second also should be a substituted judgment, which includes the doctor could use a range of evidence, such as reports of what the patient has said about this kind of situation in the past, and general values and experiences with other patients. Okay. Proxy, someone else is appointed to make decisions on behalf of the patient. And lastly, advanced directive. The patient made a clear decision in advance before the situation happen, and advanced decision must specify the treatment that is to be refused, and should apply only at the time when the patient lacks capacity. And there are also 4 conditions that should be taken into consideration when considering the advanced decision. First one, the advanced decision must be should be written. Okay, it's not a verbal one, not somebody rumors, somebody telling us about it. It must be signed. The signature must be witnessed as well. The document must be verified by a specific statement expressly stating that the advanced decision is to apply even if life is at risk. Okay, so these are conditions that should be applied for the advanced decisions. There are also there are different supporters and people who also oppose to this kind of decision, because those who support the decisions think that this is kind of respect to the patient autonomy, cause him less anxiety, and also may lead to a lower health care cost. Those who oppose to this type of this type of decision think that patients may not be able to imagine what is like to be in a disabled situation. Or for example, advanced directives are sometimes either too vague or too specific. So for example, a patient may indicate that they do not wish for certain treatment if they develop dementia, but what if they have a stroke, for example? Does their statement apply to that or not? So it's sometimes it's confusing. So those who oppose to this situation also think that sometimes some statements are confusing. Okay, I have only two last cases. The first one is the case of Mrs. R. Sorry, Mrs. R is a 66-year-old woman who sustained a severe hypoxic brain injury following an out-of-hospital cardiac arrest. She has been on medical award for more than 3 months, and it is believed that she is in minimally conscious state. The medical team have been communicating with her family, but there are different opinions. Okay, her husband believes that she would not wish to be kept alive in her current condition. Her father, who is an 85-year-old man, wished for treatment to continue. Her siblings have strong religious beliefs that life-prolonging treatment should be provided for Mrs. R. Mrs. R was religious in the past, but no longer attend church. Should the family wishes be followed, and which ones? Confusing. Which ones should be followed? What do you think? Fast, yalla. What do you think? Which ones? Which opinions, which family member should be, opinion should be considered?
So one of the participants has said next of kin, whoever the next of kin is.
Okay, in this case, who?
Maybe would the patient have recorded that somewhere?
No, she didn't record anything.
Right.
The family, there is disagreement in the family. So the medical team, who should take the opinion of whom in the family, in this family?
So Mr. Jumar thinks it's the siblings.
Siblings, okay.
And Miss Rowan thinks it's the husband.
Okay.
And somebody else thinks it's the husband as well.
Husband.
So, difference of opinions. Legal
Actually,
guardian.
Okay. To answer your request, to answer this question, law imposes a legal duty on doctors to consult a range of people when determining the best interest of a person who lacks capacity. And these people are family and can be other persons. And there are different persons that can be consulted for the best interest of the patient. Anyone named by the person himself, okay? Anyone engaged in the caring for the person, any person appointed as a lasting power of attorney, or any deputy appointed by the court. And in this case specifically, and in other similar cases, it should be the closest person who recently took care of the patient, which is the husband, okay? Next, last one. In an elderly care home, some patients with dementia have electronic tags attached to them so that nurses can be notified if they leave the care home, and they can then be located and brought back. Some staff members are concerned that this tagging is similar to electronic monitoring of prisoners. Does this represent a deprivation of liberty? Is it ethically justified? What do you think? Yalla, 1 minute. What do you think?
So Ms. Rowan thinks it's not ethically justified.
Not ethically justified.
Mr. Ali said, have they consented to wear these tags?
No, they did not. Okay, so legally, in general, okay, legally, globally, if we talk about, there is what is called restraints, okay? There are circumstances when doctors believe that it would be in the best interest of patient who lacks capacity to use threats or force in order to impose treatment on them. Such use of threats or force is called restraint. Now, there are different types of restraints. It could be physical, such as being held down, or chemical, such as using medications, mechanical, such as locking doors, and psychological. Now, two conditions must be justified in order to do this. One, to prevent harm to the patient, okay? The second one, the use of restraint must be proportionate, which means not to cause harm, but to prevent harm, not to cause harm. Now, according to the Qatari law, and this is last thing from my side, in law number 16 to 2016, the mental health law, article number 5, it says clearly, and I will read the article here: the responsible doctor or his representative, based on a reasoned psychological evaluation, may prevent the psychiatric patient from leaving the institution after voluntary entry for a period not exceeding 72 hours in either of following two cases. If he believes that his exit constitutes a serious possibility of immediate or imminent harm to his safety, health or life, or the safety, health or life of others. And second, if he thinks that he is unable to take care of himself due to the type of severity of mental illness. So lacking capacity, according to the Qatari law, in mental health situation for those who are inside the institution, if they may cause harm to themselves or the others, the law allow the institution to impose institutionalization. Okay, I will stop here. Thank you very much. And the stage of you, Tanya, and sorry for taking extra 10 minutes. Sorry. I will stop my sharing.
That's okay. I've made Ms. Tanya the presenter now.
Okay. Okay, good evening, everyone. I'm Tanya Kane. I'm an assistant professor at the College of Medicine at Qatar University. But before we start on this most romantic of evenings, does everybody want to take a quick stretch, reach up, stand up, turn around, touch your toes before the last stretch? I promise it won't be too painful. We've only got about half an hour to go. So without any further ado, take a sip of your coffee and let's get started. So as a healthcare practitioner, your day is spent with your patients and you're surrounded by their medical information. Can you give me any examples of this? I want to pull up the chat box. Hold on, I can't see your response. Oops. Hold on. Technically inept, clearly. Okay, there we go.
You got it, Tanya?
I've got it, yeah. Okay, so what kinds of medical information, personal information do you have access to? I'm expecting the last 30 minutes to be highly interactive.
Patient health records.
Excellent.
Details of previous admissions.
Really good, yep.
List of medications.
Excellent. Okay, so you review the patient's records, you listen to their health stories, you view their x-rays, their MRIs, their CAT scans, you're privy to the results of their diagnostic tests, and you treat them. You have access to their protected health information, their billing and payment information, their demographic info, their age, their marital status, photographs, lab results. You know about procedures that they've undergone in the past and what medicines they're taking. You may well know this patient better than their own spouse. This evening, we are going to outline the basic principles of patient confidentiality, and we're going to explore how patient confidentiality relates to respect for personal autonomy. Okay, let's just make sure that we're all on the same page here. What exactly is confidentiality?
So one participant has said, so Mr. Ali has said privacy, not disclosing information unnecessarily.
Excellent. Okay, and to double check, what is autonomy? If you think back to about an hour ago, Dr. Shahir talked about this.
got independence,
Mhm.
respecting the rights of the patient,
Excellent. Essentially, the patient is the boss of everything about themselves. Okay, so confidentiality is one of the cornerstones of trust that enable the patient to be comfortable with us and to open up to healthcare practitioners about their medical issues and to undergo physical examination. And when a patient discloses this personal information to their healthcare practitioner, they expect that they've pledged not to disclose this information to a third party in the future. This means that you as a healthcare practitioner have an obligation not to divulge information about this person to anyone else without his or her agreement. I hope you appreciate little comics because I got permission for all of these. Okay, I want you to think about a time when you breached confidentiality. What were the extenuating circumstances? Was it necessary? Was it by accident? Was it forced on you by those on high? Could it have been avoided? And is there anyone who's willing to share a 2-sentence synopsis with us about that time when you had to break confidentiality? I really wish we could hear you in this.
So one person's been brave, and they said to check on the blood results of a relative.
Okay, that's understandable. But it's a slap on the wrist. Anyone else? And thank you for sharing. Okay, let's go on then. Healthcare practitioners have an ethical and legal duty to respect patient confidentiality. We consider the basis for this duty looking particularly at the meaning and value of autonomy in healthcare. So enabling patients to decide how information about them and how it's disclosed is an important element of autonomy and helps patients engage as active partners in their own care. Confidentiality respects patient autonomy and privacy and helps us to cultivate trust. There are 4 ethical pillars relating to confidentiality. This is the theoretical stuff. I'll breeze over it quite quickly. So, first of all is respect for patient autonomy. This principle emphasizes the patient's right to have control over his or her own life. And by extension, autonomy allows the patient to decide who has access to their personal information. In my view, this principle is what underpins medical confidentiality. There's also an implied promise. Patients assume that healthcare practitioners will maintain that confidentiality. Our professional guidelines also emphasize the importance of high standards of confidentiality. And this view of confidentiality is different from patient autonomy because it doesn't depend on what the patient would want. It's rooted more in the concept of the doctor-patient relationship or the health practitioner-patient relationship. Virtue ethics focus on the questions of what makes a virtuous healthcare practitioner, rather than what is right to do in particular circumstances. So the patient assumes that the health practitioner is virtuous, meaning that they're trustworthy. And because of this, they assume that they will not breach confidentiality. And lastly is consequentialism. Breaching confidentiality would result in the long-term loss of trust between the patient and their healthcare provider. So there's something at stake here that's not worth losing. So when can confidentiality be broken?
So Noor has said when it's in the best interest of the patient.
Excellent. Is that the only time?
Hassan has said when there are court proceedings.
Excellent. You've hit 2 out of 4 exceptional circumstances.
And who's this? This is Fatima has said in the case of minors.
Okay, we'll get to the nuances of that. That's good. Anything else?
Rowan has said in emergency situations.
Okay, good. Okay, Okay, so there are some circumstances when confidentiality can be breached. First of all, we can breach confidentiality when the patient consents to it. For example, the patient may want us to pass on their confidential medical information to an insurance company in order to get a cheaper insurance premium. Or they might ask us to disclose their medical records for the purposes of a certain type of job. Second of all, it's generally accepted that confidential information will be passed between healthcare teams. Where patients have consented to treatment, information is shared amongst healthcare professionals to ensure continuity of care. A caveat of this should be, though, that patients should be informed that such information will be shared, and should the patient wish to restrict disclosure of this information, then you must respect this. We as healthcare practitioners have a duty of disclosure to statutory bodies such as the CDC for communicable diseases such as STDs, TB, COVID, food poisoning, as well as the Ministry of Public Health for epidemiological statistics such as births, deaths, termination of pregnancy, in many places if there's gunshot wounds and things like that. So we also have a duty to disclose information if a court order is applied. And I think Ali picked up on that. Also, we can disclose personal information when it is in the public interest to do so. I can't remember if it was Fatima that said that. We have a duty to warn and a duty to protect. For example, if we wish to prevent harm to a third party, an example might be informing a partner that their spouse has chlamydia. We also can breach confidentiality to prevent a serious crime, such as child or elder abuse, attempted suicide, or terrorism, should we become privy to some information that is passed on by a patient that would prevent a serious incident, which could be prevented, or if we disclose the information, it will save others from harm. In these cases, we should breach confidentiality. There are more common incidences, such as informing driving authorities of patients who are unsafe to drive due to conditions such as epilepsy or blindness. But usually we advise patients themselves to inform the authorities, but if they choose not to, we can do it on their behalf to ensure the safety of others on the roads. So where breaches of confidentiality are unavoidable, we should keep these disclosures to a minimum. In the case of an audit, we should try to anonymize the data as much as possible and use unidentifiable information. Where we cannot anonymize the data, it's best to seek consent from the patient before using it, if that's possible. And we also need to make sure that we as healthcare practitioners are up to date with the medical legal requirements and guidelines that apply in the jurisdiction that you are working. So it's important to know that different rules and regulations and laws define different locations. So the rules that are at play in Canada versus the rules that are at play in Qatar and China will vary. So you need to know where you are practicing. So some confidential information has implications for other people as well as the patient. This is particularly the case for genetic diagnoses that may imply that other family members are at risk of significant illness. Easy for me to say. Patients will, in most cases, agree to share information about a genetic diagnosis with family members. And guidelines recommend that patients should be encouraged to share relevant information and that their consent should be obtained before sharing a genetic diagnosis with other family members. If the patient refuses, it might still be justifiable to disclose information if there is a risk of death or serious harm to another. And there may be ways of communicating risk of heritable illnesses without breaking patient confidentiality. For instance, a daughter may be informed that she has a family history of early onset dementia without mentioning who it is in her family and what side of the family that early onset dementia is. In the case of STDs, the issue is not really whether to inform a sexual partner, but how they should be told. The best advice is to invite the patient and their partner to come to your office. Alternatively, obtain consent from the patient to inform his or her contacts on his or her behalf, because it can be quite embarrassing. I've spoken about driving, so drivers have a legal duty to report any conditions that may impair their driving and should be encouraged to disclose this information. But again, if you know that they're not willing to, it's maybe worth a call to the driving authority. Now, patients lacking capacity can't, by definition, give consent for information to be passed on to someone else. So healthcare practitioners should act in the patient's best interests. Sharing information about a diagnosis, treatment, and prognosis with close friends or key caregivers is regarded as being in the patient's best interests. Now, confidentiality in children. This is kind of an awkward sort of gray zone. So a child of 16 years or above is generally assumed to have capacity to make decisions about the sharing of his or her medical information. The doctor owes the obligation of confidentiality to the child, not the parents. For example, if they told you that they smoked, or if they came to see you about maybe getting birth control. The doctor should, however, encourage the child or the minor, so we're talking 16 plus, to discuss the matter with his or her parents. And the doctor should seek consent before sharing a child's confidential information, unless it would result in a delay that would increase the risk of harm to the child. When a child reports abuse, you must ensure that they are aware that you are obliged to report it. So confidential information may be shared without consent if required by law. In a case of suspected abuse, you should discuss it with a senior colleague before reporting it to the relevant authorities. And any decision to share information should be clearly documented, including justification for your reasons for disclosing it in the patient's records. And lastly, here is social media. Restrict your privacy settings and don't post or publish any content on social media that contain patient details or identifying information, including photographs. Pay attention to tagging of photographs and images. Avoid relationships with patients on social media, and remember that many messaging functions that you use are not encrypted. So professionalism should prevail. Now, occasionally there are accidental breaches of patient confidentiality. What should we do in those cases?
So one of our participants has said, be honest and upfront.
Excellent. It can be hard. Oops, oh no. So,
Alan has said,
oh, sorry, go ahead.
Alan has said, acknowledge the mistake.
Excellent. We have a duty to inform patients of our mistakes. So therefore, we must not only speak to the patient, but also apologize for the breach that has taken place. And if we do this, we should clearly document our conversation and the events in the patient's notes. We should also inform senior members of the clinical team because the situation may be escalated, so statements may need to be provided. And depending on the severity of the breach, it may be worthwhile speaking to the medical legal department at the institution where you work to provide legal support or legal assistance at these times. How are we doing for time? So here's the scenario. A patient is admitted with chest pain that is suspected to be a heart attack. He undergoes emergency treatment and is transferred to the coronary care unit. While on the ward, you receive a telephone call from the patient's wife asking for an update. She tells you that as she works as a school teacher, she is unable to take leave until suitable cover is arranged. You can tell she is clearly anxious. You believe the patient is doing well, but have not been to see him yet. So what I want you to do in the chat bar is I want you to rank in order the following actions in response to this situation. So 1 would be the most appropriate, so you would put that first, and the least appropriate will be your 5th answer. So your choices are, now if we could speak, we would go through each one of the options and discuss the merits of each, but we don't have capacity to do that. So I'll read the A. Tell the wife that the patient is doing well following his heart attack, but you haven't seen him on the ward round. B. Explain to the caller that you will need to speak to the patient first, but will call her back once you have received permission to speak with her. C. Demand that the caller comes to the ward if they wish to know the information, as you are very busy and do not have time to take calls. D. Explain to the caller that you were unable to disclose patient information over the phone and would like to arrange a time that is convenient for the patient, the caller, and you to meet on the ward to discuss the patient's health. This is clearly a pre-COVID case. And E. Ask the caller a series of questions to confirm her identity and then proceed with giving her information as required. This case has been adapted from a book by Green and Brady in 2016. So write your answers. What do you think the first one should be? So you're going to order those. So, and as you're saying that the first thing you would do is E, ask the caller a series of questions to confirm her identity.
So we've got some people saying E and some people saying B.
Okay. Can you all write down your answers like in order? So you've got 5 answers, try and put them in the order that you would do this because there's a scoring system.
I think we need a minute or so to do that,
Yes.
Tanya.
And you get some points for partially right answers, so don't be too stressed about this. I should have like timer music on in the background. Okay, I'm going to reveal the answers.
Repeat the music, not the answers, please.
It's difficult. Okay, so this chart's a little bit complicated, but basically the order should have been, the ideal order should have been D, B, C, E, A. So did anybody get that in order? D, B, C, E, A. So the way you score it is if your first answer was D, you would get a 4. If your second answer was a B, you would get a 4. But sometimes you're going to get them in sort of the wrong places. So the way to score your answer would be in the first position, in pole position 1, which answer did you put? So I know one of you put E first, and that was not the best choice. You're only going to get 1 point for that.
Is there a way to go back to the answers? Can we, so we can see?
I'm going to go back. I'm going to go back to an answer. Do you want me to go? Do you want me to go backwards or forwards?
Yeah, I think that's probably going to be best. So I think that's probably going to be best. So if we know that the best option was D, what was D again? Can you remind us?
Okay, I'm going to go back. Explain to the caller that you are unable to disclose information. Blah 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 blah. So you can't really have the conversation. So, okay, so the maximum number of points is 20. If you got everything in the right position, you would have got 4 for each of the scores. But it's a difficult question. Let me go through the answer with you.
So just to let you know, Tanya, Noor on YouTube, she got 20.
You're a rock star, Noor. Woohoo! Heart-shaped. Okay. So this is focusing on confidentiality, and the key is to recognize that although the caller identified herself as the patient's wife, she might be a stalker. You know, you don't know. Anybody can say they're the wife. That doesn't automatically grant her access to his medical information. Before disclosing patient information, it is required that you gain the patient's consent. Remember, the patient is the boss. However, equally important, it's to be polite and professional to relatives at all times. And both are achieved by D. So let's go back and look at D. This one here. The next best option is B. This maintains the confidentiality while also giving the relative the understandable reason for not disclosing information. She is likely to be appeased by your calling back with an update. C is the next best answer because although it is unnecessarily rude, it still maintains confidentiality, which should be your priority here above all else. The final 2 options are both flawed. However, E is the better of the 2. If the caller is able to answer a series of questions about the patient, the chances are she is indeed his wife, and therefore probably next of kin. A is the worst option, as it is not necessarily true and could cause all manner of problems if the patient has deteriorated or, even worse, passed away since you last saw him. Okay. So a few final questions. How are we doing for time? I know somebody stole 5 minutes of my time.
We're good for time.
Excellent. Okay. So I've got 4 questions here. Do healthcare providers have an absolute duty to protect patient confidentiality? This is a yay or nay answer.
We're seeing yes, lots of yeses.
Excellent. Bravo. You do have an absolute duty to protect it, though there are certain extenuating circumstances where you can override it. Okay, here's one that I think may be familiar to a lot of you if you're honest with yourself. After a tough day at work, a healthcare practitioner tells her partner about a difficult case she encountered. She does not mention patient details. Is this a breach of confidentiality? Is it wrong? And does it make a difference if her partner is also a healthcare practitioner?
Lots of no's, because no
Okay,
names are
lots of
mentioned.
questions in there. Let's start with, okay, so the question is this a breach of confidentiality? I think this is something that a lot of us do, because there's a lot to be said about debriefing after work, you know, and just venting about, you know, what you had. It's very difficult to leave it at work. Technically, it is a breach of confidentiality. She was careful not to include any identifiable information. If the partner is also a healthcare practitioner, it would really matter whether or not the patient was under the partner's care or not, because otherwise the information shouldn't be shared with that person because they're not under the direct care. The patient's not under the direct care of that person. Okay, let's move to question 3. A police officer phones the emergency department asking for information about a road traffic accident that took place earlier that evening. What should the health practitioner do?
So we've got, who's this? This is Abid, is saying that we should take steps to confirm the identity of the police officer.
And how do you do that on the phone?
Abid said, with difficulty.
Excellent. I'm not sure exactly what your hospital policy would be, but generally anybody can go on the phone and say, "Hi, I'm a police officer. Tell me about this accident that took place at 7 p.m. on, you know, Al Khalifa Road." So yes, the person should come in and should present identifiable, sort of like show you his badge or her badge, depends where we are, to identify and show that they actually are supposed to be obtaining that information. Oh, is there a police office at HMC?
I don't know the answer to that question. I don't know.
Okay, so I think that there is a process of information, release of information within each healthcare setting. So you should know what that is and don't just take phone calls and let out patient information. Okay, last one. A patient is seriously ill in hospital and lacks capacity. Is it a breach of confidentiality for his healthcare provider to discuss his medical condition with his children? This is going to be rapid fire. So can they discuss it with his children? Yay or nay?
Lots of yeses.
Good, because they're next of kin. His ex-wife?
No, no, no. Lots of no's.
Unless there's evidence that she is the person that is allowed to make decisions for him. And his close friend?
Lots of no's about his close friend.
Exactly, unless there's documentation to say that that person is entitled to make decisions on that person's behalf. Okay, so knowing what we know, what measures will you take moving forward to ensure confidentiality? Can you give me some examples of what you're going to, like what you do to prevent accidental disclosures?
So Inas has mentioned policies.
Excellent. Adhere to the workplace policies, privacy policies. Good.
Noor has mentioned be aware of circumstances where breaching confidentiality is permitted.
Exactly. So you should be able to understand when, how, and with whom protected health information can be shared. Excellent. You're on a roll.
Abid said, sign out of Cerner when I'm not using it.
Excellent. Okay. So ensure that anything with patient information is out of the public's eye, and make sure that the information is stored on secure systems and that you don't sort of accidentally leave a file open when you walk away from it. Limit your use of mobile phones in patient areas. Consider if you really need to print off information, because patient notes, files, and labels can easily be misplaced. And think about where you conduct consultations with patients or any discussions you have with other practitioners. Be careful not to be overheard in the corridor or the elevator, the bathroom, the cafeteria, or the car park. We tend to let our guard down in these places. And always remember that the patient is the boss of what information is shared about them. So in summary, confidentiality is where a healthcare practitioner is provided information by a patient and the doctor does not pass on this information onto a third party without patient consent. By doing this, we're respecting the patient's autonomy and we're building trust with the patient. And we've also discussed that confidentiality can only be breached under certain circumstances. Thank you so much for participating, and I hope that this helps to clarify some of the ethical dimensions of confidentiality and medical ethics more generally. I'll stop sharing. How did we do for time? Oh, 9 minutes to spare.
We did excellent for time. So it just gives me enough time to thank our excellent speakers, Dr. Suhad, Dr. Tanya, and Dr. Sharia. Really enjoyed today's session, and really, I think I've got to say thank you to our participants as well for all of their engagement. So I think some of you asked about the recording. So the recording will be up online tomorrow morning, so you can access that at any point. I will share with you if you go to the QU Health CPD website, I'll share that with you now. So all attendees. Okay, and also what you'll find on the website is if you require certification for attending today's event, you just need to complete the CPD evaluation. So let me just share my screen with you. I need to make myself a host. I'm going to share my screen. Okay, so I shared this at the beginning of the session, but I'm going to share it again. So you should be able to see the event page of the QU Health CPD website. So from here, you can see all of our upcoming events. Our next event is on Tuesday, which is part 2 of our ethics series, Genetics, Genomics, and Islamic Ethics. So you can register here, and to receive your certification, you just need to click on today's link. It's valid for 7 days. So you can collect your certification in the next 7 days. It will take you to the post-event evaluation where you'll need to complete all the necessary fields, and then you will receive a certificate within 7 days of attending. So it's a nice streamlined process to make it a lot easier for you to receive your certificates. And you can see as well, we have some very nice upcoming events that we hope you'll join us in attending. So thank you once again to our brilliant speakers, and thank you again for attending, and I hope you enjoy the rest of your evening. Thank you very much, everybody. And maybe a closing statement from our presenters today.
Thank you so much for your active engagement. It made it much easier to present. Thank you. Happy Valentine's Day to anybody that's celebrating.
Thank you very much. Thank you.
So take care.
Okay. Good night, everybody. Thank you very much.